Yes, sir. Good evening, sir. Today we are going to discuss about anesthesia for TURP. The given case scenario is a 75-year-old male, hypertension for 20 years, DM for 15 years, recovered from hemiplegia 2 years ago with minimal motor weakness. So the given anesthesia concern, patient related, it's a 75-year-old male, old age geriatric patient having comorbs of systemic hypertension and diabetes for long duration and history of stroke 2 years ago with presenting with minimal motor weakness. So history of presenting illness, 75-year-old male presenting with complaints of increased frequency of micturition for 3 years, dribbling of urine during micturition for 2 years, and incomplete bladder emptying and weak urinary stream. He has no history of previous admission, no history of pain while urination or blood in the urine, no history of weight loss, loss of appetite, no history of fever, abdominal pain, nausea, and vomiting. Past history, he is a known case of systemic hypertension for 20 years on regular treatment with tablet telmisartan 40 mg BD and tablet bisoprolol 5 mg. He is a known diabetic for 15 years on OHs, tablet metformin 500 mg BD. History of stroke, he gives a history of stroke 2 years ago. And he is currently on dual antiplatelet drugs like aspirin and clopidogrel. No history of angina, syncopal attack, peripheral arterial disease, no history of ischemic heart disease, dyslipidemia, no history of bronchial asthma, tuberculosis, thyroid and thyroid problems, no history of snoring, breathlessness, cough, swelling of the feet, no past surgical history or exposure to any anesthesia drugs. Personal history, he is a non-smoker and non-alcoholic. Sleep disturbance is present due to nighttime awakening. Drug history, no known drug allergy. He is on tablet Telma 40 mg BD, tablet bisoprolol 5 mg, tablet metformin 500 mg, tablet aspirin and clopidogrel 75 mg. General examination, the patient is conscious oriented, well built and nourished. His height is about 173 centimeter, weight 63 kg and BMI of about 21. He has normal paces, no pallor, ictus, cyanosis, clubbing, lymphadenopathy or edema. His vitals are about 70, heart rate 70 per minute, regular rhythm, normal volume, BP about 150/80 on sitting position, respiratory rate 14 per minute regular, saturation about 98% on room air and afebrile. The patient is catheterized. He has no hearing aids. His gait is normal. Thyroid is not enlarged. Spine is palpable and IV access is good. airway examination, he is partially edentless. Mouth opening is more than 2 fingers. Myolymphatic grade is 2. Neck movements are normal with no restriction. There is no retrognathia or prognathism. There is no joint stiffness. Systemic examination, serious S1 and S2 heart sounds heard, no murmur. RS bilateral artery plus clear. Bilateral artery is there and the chest is clear. GAT, its abdomen is soft, and CNS, his DCS is 15/15. There is power of right lower limb is about 4/5 and left lower limb is about 5/5. Functional status of the patient, he is able to do his daily regular activities. He walks daily about 30 minutes. His meds is about 4 to 7 minutes. Breath holding time is about 15 to 20 seconds. Investigations. CBC, we look into the CBC, that is the hemoglobin and hematocrit value, and total count to look for the any infections like UTA. Urea and creatinine is done to look for any obstructive uropathy due to raised creatinines. Coagulation profile as the patient is on dual antiplatelet drugs. Blood sugar, urine analysis is done to rule out any UTA infection, to look for pustules or bacteria or ketones. Blood grouping and cross matching is done. ECG and echo is done as the patient is a chronic systemic hypertension and diabetes patient. Electrolytes like serum sodium is important as the patient is more prone for complications like Cleard syndrome. Summary, 75-year-old male who is a known diabetic hypertensive, history of stroke 2 years ago with minimal motor weakness and dual antiplatelet drugs, posted for TURP procedure. So a discussion should be made with the patient regarding the advantage and disadvantage of the regional and general anesthesia, and choice should be made after this. My choice of anesthesia would be subarachnoid block after proper neurological documentation of the minimal motor weakness. Regarding the advantage of regional anesthesia, early detection of complications such as TR syndrome, bladder perforation can be detected. Possible that is good post-op analgesia. It is lower in cost and is usually useful in patients with significant respiratory disease. There is reduced incidence of post-op nausea and vomiting, DVT and pulmonary embolism. General anesthesia is advised in patients who are unable to lie supine for long duration of time and those who have a persistent cough, and that is and due to patient preference. So we give a pre-med of analgesia, short-acting midazolam of about 0.25 to 0.5 mg, and anxiolytics can be given. Fasting guidelines: 6 hours for heavy meals and 2 hours for clear fluids. We should prepare the OT. The OT should be warm, and warm irrigation fluid should be available. Emergency drugs, airway equipment should be kept ready. We should put an IV line of about 16 to 18 gauge. Standard ASA monitoring like ECG, heart rate, BP, saturation, and respiratory rate should be monitored. Oxygen should be administered, and antibiotic prophylaxis of gentamicin of about 1 to 2 mg per kg can be given to prevent instrumentation or UTI, like prevention of infection due to instrumentation or due to UTI. Subarachnoid block is given in sitting position with 0.5 mg of heavy bupivacaine, 0.5% of heavy bupivacaine, volume about 2.5 to 3 ml with adjuvant of 25 mg of fentanyl. It should be given in the sitting posture, and the patient is lie down, 27 gauge spinal Quincke needle, and the patient should be lie down after 2 minutes. The patient is put in lithotomy position after the block settles or after 5 to 10 minutes to prevent upgrade of spinal. Spinal level required for TURP is T10 level, and we should watch out for hypotension. We should look for the intro complications like hypothermia, blood loss, hemorrhage, bacteremia, perforation, penile erection, TURP syndrome, and glycine toxicity. Hypothermia, as a pediatric patient, they have decreased thermoregulating capacity, and the shivering mechanism is lost in the area of block, so the metabolic response is abundant. Due to cold OT table and operating room and cold irrigation fluid, they are more prone for hypothermia. Bacteremia and sepsis. Bacteria from the infected urinary tract may enter the bloodstream, may present with rigors and hypotension. Hemolysis can occur due to the irrigation fluid. Blood loss and hemorrhage. Blood loss, these are difficult to quantify. The amount of blood loss is directly proportional to the mass of gland excised and duration of the procedure and the experience of the surgeon. Blood loss occurs due to the opening of the sinuses, like prostatic or venous sinuses. Severe blood loss can be due to clotting abnormalities, that is release of urokinase from the prostatic blood, which causes bleeding. It can be treated with tranexamic acid or epsilon aminocaprionic acid. Blood loss about 15 ml per gram of prostatic tissue or 2.4 to 4.6 ml of per minute of resection time of blood loss is lost. Perforation can be occur. It can be urethral, intraperitoneal, extraperitoneal, or capsular perforation. They can present with abdominal pain, abdominal distension, autonomic signs like pallor, nausea and vomiting, bradycardia, hypertension, and shock-like features. Intraperitoneal rupture is treated by exploration and repair. Extraperitoneal or urethral by catheterization, that's suprapubic catheterization, and antibiotics. glycine toxicity and TUR syndrome. So in TURP, there is resection of the prostate gland, and the irrigation fluid is used to distend the bladder so that clear visualization is there and the blood and debris are washed away from the irrigation fluid. So the most common irrigation fluid used is 1.5% glycine or NS. In our hospital, we use NS. It has a diathermy loop, a bipolar diathermy loop is used to dissect the prostate gland. So the ideal properties of the irrigation fluid should be transparent, non-hemolytic, easily metabolizable, easily excretable, sterile, and inexpensive. Due to absorption of a large volume of intra-irrigation fluid, it leads to dilutional hyponatremia, hyperolemia, and hypoosmolarity. It can also occur post-operatively until 24 hours post-surgery. Post-op complications like clot retention, perforation should be watched out. We should look for the hemoglobin and serum sodium levels post-surgery. We should also check the mental status of the patient post-surgery. And thank you, sir.
That's all. Okay. What is the earliest sign of TRP?
So confusion, restlessness, and mental confusion, sir.
So if it has happened, that means it is quite advanced. When the patient becomes very restless, confusion, and that is the second stage.
Okay, sir.
After a spinal anesthesia, do you expect the BP to drop in an elderly patient or remain same or become high?
Drop, sir.
Drop. Usually there should be a little drop in blood pressure. That is what you normally anticipate in any patient, even if they are very young also. Initially, after administration of spinal anesthesia, you expect the drop from the baseline BP. Initially, with the anxiety, being awake, and then being given a spinal, their initial BP will always be slightly on the higher side. Even if in a normotensive patient, you may sometimes find the BP is 140, 100 or 150, 100. Very rarely patients will have 120, 80 as a normal thing. So from this level, it will come down to either 100 by 70 or 90 by 50, like that immediately we give. But once you have corrected the blood pressure with fluids or with a supportive epinephrine, ephedrine or phenylephrine, whatever drug you use, if the blood pressure starts going up, say it becomes from 120, 80, it goes to 130, 90, 140, 100, that is the earliest indication that this patient is likely to go in for TRP syndrome. Why? Because it is primarily because of the absorption of the irrigating fluid. That is the basic pathology. So when the volume increases, what will the vascular tree do? It will react to restrict the amount of fluid coming into the vascular compartment. So it will try to increase the resistance to prevent the volume coming into the body, isn't it?
Yes, sir.
So in a patient who has had a small drop in blood pressure, which has stabilized, if it starts increasing, that is the most earliest indication that this patient is likely to go in for OSA. So in that situation itself, if you catch it, you can prevent that. By the time they start fidgeting, trying to pull out the IV line or behave in a very restless fashion, and you ask them a question, they are not able to cohesively answer. A patient who was previously, before giving spinal, very lucid, very answering all the questions very clearly, if it starts fidgeting with the IV line, he wants to pull off the pulse oximeter probe. These are all the behaviors that will give you a clue that he is going in for TRP syndrome. So if you manage it at that stage itself, you can prevent a full-blown TRP syndrome occurring. If you miss the bus at that level, then he will become very restless, he will try to get up, he will throw a fit, and he will become unconscious. That is how the series will go. Okay, so that disorientation is a little advanced stage of TRP syndrome. So don't wait till that time. Always monitor their BP every 5 minutes. And if the especially diastolic BP starts going up from 80 to 90, 100, that is the indication that more fluid is being absorbed. So what are the steps that you will take, or what management you will do if you find the blood pressure is going up?
We should ask the surgeon to stop dissection and
Okay.
achieve hemostasis and immediately come out, sir.
No,
Stop the
now
IV fluid.
only the BP is slightly high. Patient is calm. Patient is comfortably lying. If you ask the surgeon to stop at this level, will he do that? Now he will ask you, what madam, now you are making a guess that he may go in for TRP syndrome, but not actually, it has not happened.
Yes, sir.
So why you want me to stop? That is a question he will ask you.
Yes, sir.
So how to manage in that situation? Logical thinking.
We should stop the absorption of the irrigation fluid, stop the bleeding, so that more volume get absorbed into the blood.
You are repeating the same answer. Stop the resection means the surgeon is not agreeing. He says, why sir, BP 150, 100 now? Why are you asking me to stop? I am not having too much of bleeding here. I will resect it quickly. So without knowing that the surgeon is understanding about the TRP syndrome, what are the measures you can take from your side to prevent the occurrence of Turp syndrome? That is what I am asking.
Stop the IV fluid, sir.
Not stop. Reduce as much as possible your IV fluids. Then how will you excrete the excess fluid that you suspect that will come into? Diuretics. Quietly give 20 milligrams of Lasix. Reduce your IV fluid as much as possible. Within 5 minutes, the BP will again come down. Okay. So without telling the surgeon that there is a possibility of Turp syndrome happening, you can quietly manage the whole stroke, and you can allow the surgeon to continue with the surgery also. Okay. So why I am telling you is because of my experience with more than 1,000 cases of TRP with a urology surgeon. I have observed that this is the earliest indication that rise in the blood pressure, especially diastolic. When it happens, don't just simply wait and watch. Reduce your IV fluid intake and never preload or co-load this patient drastically, because they will definitely have some amount of fluid getting absorbed into the circulation. Their volume will automatically increase. So never preload or co-load these patients rapidly to correct the hypotension. Rather, you can give 3 or 6 milligrams of ephedrine to improve the BP if it is drastically falling, rather than resorting to fluid resuscitation for hypotension. These are the two practical points that you have to take into mind to prevent a Turp syndrome happening, which is merely excessive absorption of the irrigating fluid into the circulatory compartment. Okay. So the treatment or management of raising BP after a stable BP at least during the early 30-40 minutes of resection is to reduce your IV fluid, give 20 milligrams of Lasix without telling the surgeon. Surgery will go on smoothly, and you will have a good urine output in the post-operative period also. What is the advantages of having a good urine output, especially with the diuretic in the post-op phase?
Reduces the absorption in the lungs.
Absorption in the lung. From urological point of view, I am asking, what is the advantage of
renal protections?
There is no obstructive uropathy, sir.
Obstructive uropathy is not there, man. You are not understanding my question. What is the surgical complication you can prevent by giving a diuretic and producing a good diuresis?
Clot retention, sir.
Clot retention will not happen. That is why even whatever smile bleeding is there, it will all be washed out in the urine. Okay? Clot retention is a very major complication. That is happening because of the reduced urine output. Blood which is flowing there is not coming out along with the urine. It gets clotted and clot retention occurs. Okay. So if you have a continuous urine output as a good diuretic effect of the Lasix, then the whatever minor bleeding occurs will be washed out and patient will never go in for clot retention. That is the another post-op advantage you will have there. Okay. Is there a possibility of visual loss post-operatively?
Yes, sir.
Yes, sir.
Due to glycine
That
deposition.
you have not mentioned.
Yes, sir.
You said your hospital you are using only normal saline, so you are not likely to see that. Which irrigating fluid will produce visual loss?
Glycine.
Glycine. 1.5%.
Glycine. What is the mechanism? How does glycine usage can produce a rare complication of post-operative visual loss?
Glycine gets deposits on the retina, sir. It's a inhibitory neurotransmitter, non-essential amino acids. So it,
Will undergo orbital pathway.
Orbital pathway. Is it temporary or permanent?
temporary, sir.
Temporary. It will gradually improve. Do you have to do any interference or treatment if the patient complains of sudden loss of vision post-operatively?
Reassurance is in.
Arginine, sir.
Reassurance.
Reassurance. Any other drug or any treatment that you can
Arginine,
offer?
sir.
Arginine.
Arginine.
Yes, you can inject arginine. It's available oral as well as parenteral form. It will entrap that glycine and prevent the worsening of the condition. Okay. What is the difference between the visual loss after spine surgery in the prone position and the visual loss happening here in TURP?
Spine surgery is due to a compression, sir.
What are the theories proposed for visual loss after prone position spine surgery? Is there only one reason or pathophysiology or different pathophysiology is described for spine surgery? There are two theories, no? Central artery occlusion
And anterior ischemic complication.
and ischemic retinopathy. Okay, these are the two things that have been described. So it is something different from that. So if any smart examiner asks you this difference, you should be able to say. Okay, so visual loss is a common complication. I mean, not a common, rare complication after spine surgery in the prone position also. So they can suddenly ask you to compare the two and ask you to explain how it is different from that. Okay, that is another thing that we have to remember. So, so most of the things that you have mentioned, and another thing is in this case scenario, I have given that patient has recurred from hemiplegia.
Yes, sir.
So, did you ask about the past history of how the hemiplegia happened, whether the patient was admitted in the hospital at the time, what was the diagnosis, what are the reasons for hemiplegia?
Hemiplegia can be ischemic or hemorrhagic.
Hemorrhagic. Very
Yes.
good. Excellent. So, which is more common? Ischemic hemiplegia
Ischemic
is more common. Ischemic is more common.
Ischemic.
So, why you should know the difference between ischemic and hemorrhagic?
The patient is a known hypertensive, sir. So if it is not controlled, it can give rise to a hemorrhagic stroke. Hypertension related complications.
So, how to diagnose whether it is ischemic stroke or hemorrhagic stroke?
CT.
CT brain will tell you the difference. Very good. So, in hemorrhagic stroke, what drug should be avoided?
Aspirin.
Antiplatelets should be avoided.
Anticoagulants.
Anticoagulants should be avoided. Whereas in ischemic stroke, that is the mainstay of treatment. Okay?
Yes, sir.
So, a wrong administration of anticoagulant or antiplatelet in a hemorrhagic stroke will worsen the patient condition. Whereas ischemic stroke will improve by giving antiplatelet, and so that history is very, very important. You must ask about how he was diagnosed to have stroke, whether he was admitted, whether he was on any ventilatory support, whether he had any difficulty in swallowing, because the chances of aspiration are more whether all those difficulties have now completely resolved and patient is able to eat normally, drink normally without getting aspirated or choked is a very important history. Even though I am saying that he is having minimal motor weakness now, that is with regard to his gait and walking. But with other swallowing and other things also motor activity. So that you should try to find out and ask the history about they had a previous stroke, how it happened, when it was diagnosed, what type of stroke it is, whether old records are available, whether any treatment at the time, when they did any clot busting therapy like the tryptase or other clot dissolving drug therapy was given, or whether any mechanical dissolution of the clot was attempted. All those history is very important. Okay. And now, if this patient is having or being, you said he is taking clopidogrel and aspirin.
Yes, sir.
Did you mention about how long before the surgery he has to stop that?
No, sir.
That also is very, very important history. Okay.
Yes, sir.
And another thing you have not included is whether the patient was advocated any medical management before advising surgery. Was he put on any drugs to treat that condition? Because milder grades of BHP,
Yes, sir.
enlargement of the prostate, can be managed with medical management also. What are all the drugs that can be tried?
Alpha
Alpha blockers.
5-alpha reductase inhibitors and
Straight away they put on 5-alpha reductase inhibitor.
alpha blockers, sir.
Alpha blockers.
Alpha blockers.
Prazosine.
Normally given
Azosine,
Prazosine.
Prazosine, Silodosin.
Stamsulose.
Tamsulosin.
How do they classify the alpha blockers that are in use?
Non-selective, selective.
Non-selective,
Alpha 1A,
selective.
alpha 1. B, alpha 2 blockers.
Okay. Then duration of action. Short acting, intermediate acting, and long acting. Okay, so three things are there. Alpha blockers are non-selective, selective. Alpha 1A and 1B are selective alpha 1A blockers. Duration, short duration, long duration. Okay, there are all these classifications are there. What is the role of phosphodiesterase inhibitors in BHP? When will you advocate a patient to take sildenafil, which is a phosphodiesterase 5 inhibitor for PURP problem?
BPH with erectile dysfunction.
Erectile dysfunction. Combined BPH and erectile dysfunction, you give sildenafil. Otherwise, third drug is only the alpha reductase, testosterone reductase. So these are that medical history is also important. If supposing the patient is continuing one of the medical drugs that is being prescribed for BHP, which drug you have to stop?
Prazosine, sir, before 48 hours, sir. And we have to continue with calcium channel blockers.
Very good. So it is not given for hypertension. It is given mainly for if the patient who is a non-hypertensive who is taking prazosine for BHP, you have to stop that because it is also having a alpha blocking effect. It will reduce the blood pressure also. Even though primarily it is given as a treatment for BHP, you have to be aware of that. Okay. What is floppy iris syndrome? Have you heard of that? Floppy iris syndrome, and which drug produces it? And what is
Beta blockers, sir. Beta blockers.
Beta blocker and floppy iris syndrome. Iris in the eye. It is nothing to do with heart. Supposing patient develops cataract with BHP and he has been on a particular drug, he goes for cataract surgery. This will be problematic. Okay, you check and tell me the answer.
Yes, sir.
Alpha blocker, I think, sir.
Which alpha blocker? You are right. Alpha blocker is drug, but which alpha blocker? You are prazosine, doxycycline, or
Tamsulosin.
tamsulosin? Yes, tamsulosin is the drug. Okay. Sorry, this is not the one. Okay. Yes.